adjunctive therapy is not adjunctive. The way that we once were treating hygiene patients and doing SRP is no longer the gold standard.
No. What's up, dental peeps? It's your girl Irene here with Tooth or Dare podcast. Hold on to your suction. It's about to get slippery.
Welcome back to another episode of the Tooth or Dare podcast, Peeps Op Talk edition with your peep Irene and
Vic.
Honors.
Hello.
Honors Vic. The Honorable Vic. We've got a question from the pin post on Instagram about probiotics.
Yes.
Let's do it. What is it?
All right. So the question is, I'm not 100% sure, but I think a few months ago you posted some content that involved placing probiotics into pockets after SRP. If so, can you tell me what kind of probiotics you used? I work in a perio practice and I'm looking for a cost-effective adjunct to SRP for patients who decline Arestin, usually due to cost. Currently, I do sub-G irrigation with peroxide, then place Arestin. And for patients who decline Arestin, I just do irrigation with peroxide, but I'm hoping to do more.
Got it. Cool. Okay, so let's talk about that probiotic itself, but let's take a step back forward too. Let's take a step back forward. Let's take a step back to treatment planning.
Yes.
So I worked in a perio practice for many years. Dr. Marvin Budd, who I talk about lovely because I love him and he's just so wonderful. And I still work with him now as referring to him. And one thing that I found very interesting is that none of the treatment was completed until he did a comprehensive treatment plan presentation, which included anything and everything that needed to be done in dental hygiene. So there was no opportunity for someone to decline something because it was all part of that initial assessment.
They already knew.
They already knew that this is what they needed to get. And I'm on this fence all the time of not dismissing patients, but like politely declining to not do the treatment that they need. Because this is the rabbit hole that we're getting into. We're getting into this insurance doesn't cover it rabbit hole. And insurance is never going to cover any of these things. Like
it's going to continue to cover less and less.
It's getting worse. Yeah. And the less you bill for what you're doing or the less you don't bill for what you're doing, the more insurance companies are going to be like, oh, well, I guess we can just discontinue this code altogether.
They don't need it.
No one's really using it anyways.
Yeah.
So I think yes, we want a cost-effective opportunity. People are entitled to decline treatment if they choose to.
Absolutely.
Like, I'm still going to answer this question, and obviously it's still a very valuable thought process. But
it's a very practical situation. It happens all the time.
Super practical. I mean, there's a little bit of overhead and explanation necessary, but overall, I think that we should still be considering that adjunctive therapy is not adjunctive. The way that we once were treating hygiene patients and doing SRP is no longer the gold standard. No. As sharp as your instruments are, as wonderful as your cavitrons and piezos and air polishers and ultrasonics are, science is still telling us that this is a bacterial microscopic issue that we need to be solving with microscopic solutions, which is why probiotics are so helpful. But sometimes you need more than just a probiotic.
Absolutely.
Irrigating with hydrogen peroxide, I love that. I mean, there's a study that we talked about in a different episode where we built our perio protocol based upon it is going to help with healing, but it's also not strong enough to be the solution for all patients.
Yes.
So having solutions is really important. So I don't know if this is an opportunity to look at the treatment planning system and think about how do we build that into case acceptance before someone gets into the op? What do you think?
Yeah, I agree. I think that it's going to bring you more, it's going to bring more value to sit down, even though it takes time, sit down, go through every single little thing that needs to be done for the year. Like you said, you do, right? And plan it all out. The patients they know what they're getting into when they come to that appointment. There's no surprises. And I mean, yes, sometimes you do have to adjust it a little bit, but that's life.
Yeah.
But at least they know the bulk of what they're expecting to run into.
And ideally, if you're doing it right the first time, you don't need to do it again.
Yeah.
And this becomes the conversation like, oh, okay, well, let's just try this and see if it works. We know it's not going to work.
Yeah.
Like scientifically, it's been proven that scaling and root planing alone isn't enough
Exactly.
for generalized pocketing over 4 millimeters with generalized bleeding.
You can only remove so much.
Right. And then the refractory aspect of it, within 6 months, you're back to where you started again.
Exactly.
So something as simple as using a hydrogen peroxide will help, but is not going to be the solution. Something as simple as using a probiotic is also going to help, but sometimes you need more. The unfortunate thing about what this person is doing is that if you're incorporating a probiotic, you can't irrigate with hydrogen peroxide. It's not that it's contraindicated, but you're going to kill the effects of the probiotics. So you kind of have to choose your own adventure. Yeah. I localized place a probiotic in a deep pocket, and then I generalized place it to the tongue, and then have the patient smear it all over their teeth. So I use a BioGaia probiotic that has 2 different strains of Lactobacilli reuteri. Those particular types of positive bacteria are not found in like our general consumption of foods and beverages. It's a bacteria that's delivered from mom to baby after birth, and unfortunately, it only comes in a drop or in a lozenge. And in Canada, we can't get it in the drop form, so I smuggle it over the border. I'm saying that out loud. I go to a trade show, I ask for a sample, and I bring it. Sue me. Oops. And they're in the process of getting it. I think it's a labeling thing and a Canadian having things in French, but generally speaking, the dose is 10 drops, 5 to 10 drops. I place it on the back of my glove. I dip my probe in it, and then I deliver it to the pocket with the probe. Yeah. Now you'll have to rinse and irrigate with something else. You also can't rinse or irrigate with iodine. So it needs to be in a non-pocket filled with anything other than water. So you're using a distilled water or a regular water or your air water syringe. And that's it. And so it's super simple delivery. The vial itself is not that expensive. So even if you don't charge anybody for it, it's going to be at a benefit, but then you can't irrigate with hydrogen peroxide. Yeah. Really interesting pieces of research that we'll link before on the use of probiotics intracellularly for refractory perio. So there was a perio case. I don't have all the numbers in front of me. I'm just working off of memory, but there was a perio case that's cited where they did SRP alone and then SRP with probiotics. You might have it in front of you, and I don't.
I don't, but I know exactly what you're talking about. Yeah.
Let's just take a moment to appreciate the nerd level right now of like being able to cite research by memory. But basically, they had a refractory perio case. They took perio patients SRP alone, and then on the other side, they did SRP with probiotics in certain pocket depths. I believe that the average pocket depth reduction was somewhere between like 1.63 and 1.73 millimeters over the course of 28 days.
It was something.
We'll link it below. We'll link it below. But like the findings were really helpful that it reduced that pocket by like over a millimeter. In certain pocket depths. So that was one that we really liked. And then there was another piece of research that looked at bleeding on probing, the reduction of bleeding on probing. Yeah. That one was over 45 days, I think, and hundreds of patients in that particular piece of research. And that really was like a significant improvement in bleeding sites as well, coupled with SRP.
That one's in your lecture.
That one's in my lecture. Yeah. I would love to see a standard of care, throwing it out there for SRP, to be a 2-step SRP instead of a 1-step SRP. Yeah. Argue with me on this one. So step number 1, patient comes in, we do our, disclosing agent, we're removing supragingival biofilm, we're perioprobing, we're diagnosing SRP. And at that appointment, we're delivering probiotics. Yeah. And then appointment number 2, when they come back, or 3 so this is my process. So appointment number 2 is SRP right side, SRP left side. At that appointment, I'm doing SRP, hand scaling, supragingival, subgingival, biofilm removal, calculus removal, with desiccation therapy. Yes. Throwing it out there. So you're using desiccant, you're desiccating all of the biofilm on that right side. You're scaling it all out. You're cleaning it out. I'm not using my airflow at this point, by the way. I'm going straight into instrumentation. At that point, I've removed all of the calculus. I'm irrigating with hydrogen peroxide. I am then disclosing. And then I am removing all of the biofilm that's remaining on that side. And then I finish it off with a laser.
Mm-hmm.
And then I bring the person back for the same treatment on the left side. They come back for their 4 to 6 week reeval. I do a full mouth probe.
Mm-hmm.
I do a biofilm removal, re-education of oral hygiene instruction, and then you deliver a probiotic then intracellularly at the same time.
Yeah.
At the first SRP appointment or at that first appointment where you delivered probiotics intracellularly, you're also giving them the lozenges, and then they're starting their at-home probiotic using lozenges twice a day, morning and afternoon, after a meal. So the reason that they recommend the use of it after a meal is because obviously you're in an acidic state. The lozenges are xylitol sweetened, so that helps neutralize pH. But it also is repopulating the bacteria that's fighting for fuel, the fermentable carbohydrates and so forth, and providing like a good bacteria to combat the bad bacteria or the pathogenic bacteria. I think that should be the standard.
That would be nice.
For SRP.
That would be very nice.
And then after your 4 to 6 week reval, you reappoint for your 3-month appointment. At that 3-month appointment, the use of a laser again. So disclosing agent, biofilm removal, irrigation, and then, how many times do people retreating? That's another question we should have is like, what does a 4 to 6 week reeval look like?
Yeah.
And at what point do you retreat refractory perio? But argue with me that that's not the way that we should be treating perio.
No, I agree. It is. But the issue comes with everyone is so insurance driven.
Yeah.
And that's, for some reason, that's where we went with dental is, most patients only want to do what insurance covers and that's it. And we let them.
Yeah.
Right?
Yeah, we let them.
But what are you going to do? Someone's picking feeding their family or treating their perio, right?
Yeah. And it's because it's such a silent disease too. Yeah. If you were to tell a patient who's coming into, let's say you're a physician or a nurse practitioner, and you've got a patient who's coming in with chronic yeast infections or chronic BV, and they need some sort of suppository that's not covered, like I'd be paying for that out of pocket.
Absolutely.
Like, you can take my money.
Yeah.
I will
in a second
liquid diet for a week if I need to. But it's interesting that in dentistry, obviously, like we separate the mouth as like a not so visible and symptomless.
Yes. And it's not considered medical, but it is completely.
Right. It's a part of the human body. Yeah. It's totally medical.
Yeah.
So that's my answer to the incorporation of a probiotic. It as easy as giving them lozenges before, and then it's, they suck on the lozenge. Takes about, it says on the package about 10 minutes, but I find that for me, they only last about 5 minutes in my mouth.
Yeah.
So five minutes, not chewing on it, sucking on it right after a meal.
After brushing.
Yeah. After brushing. Yeah. Brush, clean, floss, eat, and then, probiotic. But ideally they're not inconsistent with it. Right. So you need to consistently be delivering that probiotic.
Oh, absolutely.
So that's what I would say to her. It does still come with a cost. So if those sheaths, it comes in a box and there's 2 sheaths, it's about 2 weeks worth, not 2 weeks, 1 week worth, I think. Depending on how you're providing it. But
I think the bottle has 30.
The body has 30. The bottle has 30 lozenges. So you can decide how you deliver it. But that still comes at a cost too.
Right.
We have incorporated all of that stuff through Amazon. So instead of stocking a ton of it, we've got some on hand that we give people that we need to get them on it before we start SRP. So we have enough for those patients, but we don't have the replenish amount.
Yeah.
So we created an Amazon storefront for the office. And for me, like you could access it on my Instagram in my bio, and created little carts with all of the things that they need for that. There's one for gingivitis, one for perio, one for kids, one for bad breath. And then each one of those carts has the things that they need it. We send them the link via text and then they can access it. So that's an easy, you know all about that, Vic, because you helped me put together the US one.
Yeah, I do.
It's actually kind of smart, I think.
I love it.
It was, I don't know anyone else that does that. So steal my idea.
Yeah. It's free.
Ideas are free. So that was that question. Did we satisfy that answer?
I think
was
we
there any
did.
other parts to it?
No, I think that was it.
No. If you're delivering the liquid probiotic instead of a lozenge, so I have a 30 tablet container in my SRP bin where I deliver the dose of the first lozenge just in order to get them like enough time for them to buy it or drop it off or whatever it is. If I don't have that, then I put drops on the back of their hand or on a clean glove. And then I have them lick it off of their back of their hand or the back of the glove. Obviously, I'm not giving them the bottle and the bottle stays with me. So the back of the glove or I just back of the glove in my finger and then I smear it everywhere. But ideally, they're delivering it to themselves.
Yeah.
That's a question.
Yeah.
Cool.
That was good.
That was it. We did it. Okay, everyone. Thanks again for tuning in to another episode of the Tooth Order Podcast, Op Talk Edition. If you have any questions, head over to Instagram, Toothlife.Irene. 3 pinned posts at the top of my page. 1 for clinical questions, anything that you may want to know about. Answers are all in the comments, and then we may take them and create podcast episodes like this. And of course, the free resources. If you are trying to elevate your perio game and do more, a systematic approach to periodontitis and treating SRPs, then download the resource for SRP for perio. And we've got a few other new ones that are coming up. So check those out soon. Until next time, peace out, peeps.